Diagnosis and Overtreatment with Dr. Ian Charlton from Kincumber Family Doctors. Before we begin, I'd like to acknowledge the traditional custodians of the land that we're all meeting on today. For myself, that is Darkinjung country, and I'd also like to pay respect to all elders past, present, and emerging. Now, we are recording today's session, so it will be available for you to view in the Education Library. You all have access to your cameras, microphones. We had a panel discussion planned for today, but we have just instead the lovely Dr. Ian Charlton to lead the way. So please, let's keep this an open conversation. Please feel free to contribute, ask any questions. We have some medical students, first-time Oscars here today, so welcome. Thank you for coming, and we like contribution from everyone. So we'll hand it over to Dr. Charlton.
Thank you very much, everybody. And certainly, yes, I pay my respects to the elders of our area, the Darkinjung people as well. Well, before we start, perhaps I should just take you for a little tour of my surgery, because I understand this is all about trying to introduce people to the great merits of general practice. If you're thinking about a career in general practice, I'd certainly encourage it. Well, perhaps I'm biased, but you can have a lot of fun in general practice. And for example, you can perhaps see here is my spirometer. There we go. I have a spirometer that's plugged into my computer, so I can do spirometry there and then on the spot for my patients with COPD and asthma. It gives me the lung age of patients, so people who are smokers, if you want to confirm that their cigarette smoking is making them older than they really are, the spirometer is a great little tool for that. And as I say, and I bought this about 25 years ago for about $2,000, and you do get remunerated through Medicare. And I reckon that my spirometer has earned me more than my BHP shares, so a very worthy investment. I've also got this fantastic little toy. This plugs into my computer, and it's an oroscope, and I can actually see people's ear canals on my screen. And the kids love it. They love to be able to see inside themselves and flash their eardrums actually up onto the screen. And we'd often be able to convince people that no, they don't have an infection, they're just congested, and they therefore don't need antibiotics. So it's been a powerful tool. And I'll just move behind me to introduce you one of the panel members who's with us today. It's Montgomery. And Montgomery lives in, there we go, you can see there, Montgomery lives in my cupboard. And so I do, one of these people that does have a skeleton in the cupboard. But Montgomery, who is there, and I practice my ventriloquist act with him to, once again, entertain the kids. They all like to say hello to Montgomery when they come and visit me. But Montgomery's very good for showing people how the spine works, where muscles attach, where the ligaments are. When I do joint injections, I can show people where the needle's going to go. And I've come to understand that if people understand their treatments, my treatments are twice as likely to work. So all these tools are very useful at helping people understand their illnesses and make my treatments work more effectively. But I'll put Montgomery back in the cupboard. As well as a host of obviously wall charts and things like that. So today, and this came from a discussion with Georgia a few months ago, wanted to talk about overdiagnosis and overtreatment. I was fortunate to go to a conference in Oxford put on by the British Medical Journal 10 years ago now, on just this very topic of overdiagnosis and overtreatment. And it made me very aware that, well, just about everything we do has side effects, and we just have to be careful about managing those side effects as well as the benefits of all our treatment. And it's sometimes quite a difficult challenge to explain these things to patients about the harms as well as the benefits of our treatment. And so I suppose like a lot of you, I've developed techniques of explaining this to patients And these explanations is what I like to share in these vertical integrations, and hear how perhaps other folk explain to their patients how they these tricky concepts. And the way I've developed explaining it is really just a collection of all the things I've read about, experienced, gone to talks and lectures, and I've sort of built up, as it were, my own concept about things using all the various bits of information that I've come across. These little stories that I tell patients, I sometimes feel a little bit guilty about them because they're often information was something that I discovered 5 or 10 years ago. Just sometimes it's a sentence in an article that seems to resonate with me, and then I build that into my education model, I suppose is the way you'd explain it. And I use these models and stories to explain things to patients. Yes, they're my stories, and I'm sure you could find holes in them and be critical of them. And you do need to be mindful about continuing to try and update them so that they're at least reflect the modern information. But at the same time, I find nowadays that the information is so diverse that it's sometimes hard to find the facts. And when you do find the facts and want to go back and check it, it's no longer there. It's very hard to find, and I'll explain this a little bit later. Also, you come across new studies that are almost contradictory to the studies that you recently reviewed. So once again, you start to find that you're relying on your own experience as well as the bits and pieces of information that you've gathered together. I'm sure you're all aware that many meta-analysis, one meta-analysis can say that something is helpful, and another meta-analysis that includes 1 or 2 extra studies can say that it's not helpful. And these are the things that we GPs have to obviously wrestle with every day with every patient that we come to see. So the one I wanted to start with today is just on prostate cancer. We have lots of fellows who come to see us and say, Doc, what should I do about my prostate cancer? And so I'd like to, well, they don't have prostate cancer. They want to know what to do about prostates because their friends have told them you should go and get your prostate checked because they had done and found that there had been a problem. So they come to me and say, what should I do about my prostate? So hopefully you can see the screen there. This is my iPad, and I have a piece of paper just on my desk where I draw out these drawings as a way of trying to explain to people the problem. So here we have prostate. Oh, hold on, I better just start this up. There we go, prostate. Is that all coming through for people okay? Thumbs up, you can see that? Great, okie doke. Prostate, so if we take 1,000 fellas, for example, we know that 90% of them, if they do have some prostate, it'll mostly be benign prostatic hypertrophy. And of those fellas with a harmless swelling that can certainly have you knowing every public toilet on the Central Coast or getting up 4 or 5 times each night, we know that probably about 90% of those we can help with our treatments these days, duodarts and the like. Unfortunately, 10% can't be treated, and these fellas, now, can I shrink up? These fellas, yes, we might have to do a TURP on them. Okie doke. And that's the majority of people with prostate troubles. Now, 10% are not benign prostatic hypertrophy, 10% are cancers. And that certainly alarms all of us. The good news there is that, and once again, it depends on the studies that you read, 90% are harmless cancers. Harmless. My pen's not working very well. 10% are certainly harmful. And they're certainly the ones we wanted to be concerned about. Of the harmful ones, the sort of good news there, once again, I'll see if I can just move my screen up. Hold on, 0 in, 0 now, I've got to go the other way, 50%. see, 33%, there we go. Of the harmful cancers, 10% are treatable. Oh, sorry, 90% are treatable. 90% are treatable. 90% are treatable with our hormone therapies and our chemotherapies and all those sort of things. You'd be pleased to know that when I draw it on paper, the writing is a lot better. But 10% are not treatable. Unfortunately, these are the fellas that end up dying. But if you do the sums, you find that 10% of 10% of 10% of 1,000 is one fellow, which is bad luck for that fellow. But the rest actually will do all right. What we understand, though, that if you go and the problem for us is these distinguishing the harmful cancers and the not harmful cancers or harmless cancers. And what they find, and I've come across this in research, is that if you go looking for these harmless cancers or trying to make the distinction, you make 60 to 70 fellas actually worse from overdiagnosis and overtreatment, exposing them to even radiotherapy. They're ending up with erectile dysfunction, problems from the therapies and so on. And that's the balancing act we have, that if we go screening for prostates, we certainly may be able to help one fella, but the trade-off is that we make 60 to 70 worse. And when I explain this to fellas, they go, oh, well, I don't have any symptoms at the moment. I'm not going to every public toilet on the Central Coast. I'm not getting up 4 or 5 times a night. I don't have a family history. I don't have any other obvious symptoms or risk factors. Thanks very much. I'll go and enjoy life and not worry about this. So that's, as I say, the way I explain it in the consultation. I welcome your views of what you do and whether you feel that my numbers are correct. Interestingly, at the conference, the British Medical Journal Conference in Oxford, many presentations were on the same topic, but for different clinical conditions. And you came away from that conference thinking that all adenocarcinomas have the same algorithm. So breast cancer has the same algorithm. Thyroid cancer has the same algorithm, and also even bowel cancer, they said had the same algorithm, although they were a little bit more circumspect about that because they felt that there hadn't been enough studies done. But if you start to think about how the body works, that adenocarcinomas in different parts of the body, do they behave differently, or are they really the same sort of beast just turning up in different parts? And if adenocarcinoma of the prostate causes this algorithm, which has been fairly worked out, is it reasonable to apply perhaps this algorithm to other adenocarcinomas in the body? So that's quite a bit confronting for us as doctors who have been trained to pursue all of these medical conditions and screen our population. But I contend that in doing so, we unfortunately find ourselves making quite a chunk of people a little bit worse off. And so I've almost defaulted now to waiting until a problem turns up and then getting on and treating it, because the treatments are certainly so much better than they were 20 years ago. Our hormone therapies for prostate cancer and even our chemotherapies, if those ones fail, are just miraculous. I can't believe how well people do on these modern treatments these days. And that even, yes, 20 years ago, if somebody had advanced prostate cancer, we'd say, sorry, mate, that's job done, get all your affairs in order. But now we can quite rightfully give people a lot of hope. I might throw to the panel there now. Now, we've got Oscar, who's our new trainee, who's about to join us in August. He's currently working in the hospital setting. He'll be joining us in general practice, and I'd certainly welcome his thoughts on this as we're going to be explaining this over and over and over again to him, and he's going to be challenging me over and over again about it. So, Oscar, what's about your thoughts and experiences with all of this so far? You'll have to take yourself off mute. That's the way.
Yes. Firstly, thank you for the warm welcome. Yeah, I think the numbers essentially speak for themselves. You know, with the anecdote or, you know, the saying from other professionals that people essentially die with prostate cancer as opposed to from prostate cancer might be quite telling and possibly quite accurate as well. But I guess with what you're saying is that, you know, over investigation obviously could be quite detrimental to someone's, you know, dignity and their livelihood and yada yada yada. But you know, to only kind of investigate when a problem arises in this instance, especially if it's, say, you know, 1 in 1,000, that's going to be you know, a catastrophic case or a tragic case, I think makes quite a lot of sense. Yeah.
Yeah, we'll go right to the other extreme and just ask Dimity. Dimity, are you the oldest person here? You'll have
Hang
to.
on.
Yeah.
I'm laughing. I don't think I'm quite the oldest person, but you never know. I might be. So I do think getting older puts a different perspective on things. And perhaps our desire for treatment is modified by the thought that, well, you know, I'm doing okay as it is. I don't really want to get any worse. I don't have to worry about erectile dysfunction, but there are other things that might happen to me as a result of treatment. So if I can potter along and keep active and keep enjoying life, and things don't look too grim, then I might not. I might not pursue something very active that has potential side effects. And my patients tend to be of that perspective too, especially once they hit their 80s and 90s. Do I really need this? They say. I'm not sure I'm going to be alive for another 10 years.
That's a very good point. And I think that's influenced my approach as well, because as I've aged, my patients have aged, and I must admit the bulk of my patients are now in their 80s and 90s. Anybody over 90 looks at me aghast if they think that I will do something that might prolong their life. In fact, and you know, I get this firsthand from my mother, who's 92. Her first opening conversation with me just about every time is, "Please let me die. Don't you do anything." And why doesn't the good Lord take me? You know, so that also is I'm being exposed to that influences as well. What about Chris? Chris Starling, how do you approach all these sort of things?
Yeah, very similar. I've just shared some resources in the chat, actually. So I pretty much just follow the guidelines, which I think I heard on the grapevine that there are new guidelines coming out for prostate screening, but I was just trying to have a look and I can't see that there's anything online. But yeah, I have very much a approach of discussing with the patient the risks and benefits of screening. I don't just tack on a PSA to every 50 to 70-year-old bloke that I see. It's very much a discussion. I always found it hard, that idea of wait for the patient to bring it up, because patients don't always know about it. That was a bit of a tricky one for me. So I tend to bring it up myself, because, you know, have you heard of this test? Do you understand the pros and risks, benefits of it? One of the links I put in there, it's getting a bit old now. There's an RACGP, almost like a decision aid. That's the second link there, which has a really nice picture of, you know, if you have 1,000 men, and this is how many will have prostate cancer. And I think that's really useful to discuss with patients in terms of risks and harms and so forth. And then I definitely don't screen above 70. I'm very much case finding then with that group. So similar to you, Ian, I definitely don't think it's something that you just, you know, order a PSA on every man above the age of 50.
Ian, can I say something?
Yes, please do.
So it begs the question, Ian, that one thing that you have raised is PSA. If we screen all the young people over 50 or something, between 50 and 70, how many people are actually going to have malignant cancer, and is it cost effective? So in some ways you're raising the question, is it worthwhile spending money on PSA and doing so many tests, and then how many are we picking up, and how many out of them are going to have metastatic disease, or how many actually have malignant disease? And so that begs the question that we need to find a more accurate test to diagnose prostate cancer that can be used more, so which becomes more cost effective as well. So we need to find a more accurate test for prostate cancer that will accurately tell us, higher values will indicate surgery and lower values are not worthwhile, so that we can it becomes more cost effective. But at the same time, I found patients as young as 55 who have had metastatic disease here and there, and obviously their families are not going to sort of tell they won't be happy if we raise the question that, oh, we don't need to do PSA as a widely used screening model. And the other question is, we are having people living increasingly till 90 years of age. So are we going to abandon PSA and things like that and find a lot of these people living till 90s, having up with metastatic disease and things like that? So I don't think it's time to call it, it's time to say, oh, let's not use PSA as a screening test, and until we find another suitable alternative.
Fair point. One thing I also has recently read articles about this the all-cause mortality as a way of assessing the effectiveness of these treatments. Now, the people who advocate PSA testing, breast screening, thyroid cancer screening, all these sort of things, often use the indicator of the disease to justify their screening program. And indeed, there's studies that show that prostate screening does lower the deaths from prostate cancer, but there's all sorts of biases sneak into that. The sort of people who turn up for screening are a different sort of group of people who don't. And so more recently, all-cause mortality has been used as the endpoint for these screening programs. And the article I read, it's only one article, but this article said that for many of these screening programs, there's no difference in the all-cause mortality rates of people who are screened and people who don't. In other words, we're all going to eventually die, and that if we do pick these things up early, it doesn't necessarily prolong our life. We might not die of the particular cancer that we got screened for, but we're still going to die at the same age of people who weren't screened. So I found that an interesting concept to consider, that how we live our lives and how we end up dying is not influenced by these screening programs. I've got some other people on my screen there. Dave Grant, SRMO. Let's put you on the spot there, David. What's you're thinking about all these things?
Yeah, I was just kind of reflecting that the way that you deliver this information is just so critical, like being able to, communicate the numbers for sure, but I just imagine that the way that people respond to this will be so impacted by the kind of the stress that they've built up over the possibility of the cancer in the first place. So it's not as simple as just giving the benefits, giving the risks of the screening, but because, they've been hearing about the risks of the cancer probably their whole lives, or, at least from their mates, over the time it took them to, build up the courage to come into the GP for the test. Yeah, just wondering if you had any thoughts on the way that you deliver those risks so that they can feel a little bit like you feel like you're giving an actual balanced perspective to them, so that they can kind of make an informed decision that's not just stuck in their fear of having a cancer that's not diagnosed.
Oh, you should come to our supervisors workshop on Thursday afternoon, because it's not me, but the presentation there is on risk management in general practice. And I remember it's only dawned on to me about 10 years ago now that actually I was more of an insurance agent, that I was managing risk rather than sort of black and white answers. And yet that's what you do, find yourself weighing up the risks and trying to gather as much information on dealing with the risk of a particular condition. Feeding into that is also your management of uncertainty. And all of us have a different tolerance for uncertainty compared to others. And both the patient and the GP have this tolerance for uncertainty. And I think I'm probably on the spectrum of I can cope with uncertainty a bit better than others. It's just the way I've been put together. But that tolerance for uncertainty almost certainly will influence the way I portray these risks to people, and then the way people perceive those risks also. So it's quite a cocktail of elements that go in. And I think, yes, you just find yourself playing it case by case, recognising that your tolerance for uncertainty, your patient's tolerance, and then what you've just read yourself, what the patient has just heard from their friend down the road, all of these things come into the equation, which then goes to show that no one patient, one doctor will treat the same thing. And this is one of the things we try and tell our trainees, that there's 9 ways to skin a cat. Is that a fair, is that a mishmash of sayings, or is that people have heard that expression? But in other words, there's many pathways to the final solution, and no one pathway is exactly right. Georgia, were your thoughts on all of that?
I'm muting. Yes, no, I agree with all your wonderful ideas and inputs. I always use the line that 80% of when they do autopsies of men that have died of age 80%, you find prostate cancer in 80% of the time. So they're more likely to die with it than die from it. So that's sort of my one-liner I give to if a patient age 80 or above asks about the tests and all about the risks of surgery if they do sort of go forward, and that usually usually change their minds about testing unnecessarily. But and I found interesting though, like in the younger patients that we do test for prostate cancer, and looking for that rate of rise is interesting as well. So and a bit off topic, we did have a men's health session a few was it earlier this year or last year, about the differences between labs as well, with prostate PSA levels between, like, for instance, Douglas pathology and Lavity pathology. So there's obviously degrees of error there with causing unnecessary anxiety and a bit of an overdiagnosis as well.
Very good. Now I'm going to have a bit of mischief with the computer here. I can see we've got Laura Board, BAWD, on the screen. Laura, we haven't got a picture of you. Are you there? Often we've got people who are watching. And now she's coming on board. This is very exciting.
Yeah, I'm here. I'm here.
Oh, well, there we go. Laura, tell us a little bit about you first up. Are you a stranger from the Northern Territory, or are you?
Yeah, I wish. No, I'm a Term 1 GP registrar working at Erina at Next Practice, in a clinic that serves a fair amount of women over men. So there are a lot of new thoughts to me as I listen on.
Yes. Well, no, just tell us, just on prostates, just tell us how you're wrestling with these sort of issues.
I'm definitely using the RACGP decision brochure pathway. I think the pictures definitely help explain the risks and benefits of PSA screening. I guess what I've also noticed, and being a female-dominated clinic, is that when I see men, they're usually coming in for something in particular. And so if they're coming in for their yearly PSA, then I can tack on a few extra opportunistic kind of preventative health things too. So I think that's where my thoughts were lying was, yes, the PSA is a flawed test. But at the end of the day, I'm seeing men for it in my rooms. So it's got to be better than telling them that it's not worth it altogether, and to facilitate other conversations, and maybe not necessarily doing the PSA, but definitely having them in my rooms talking about it is beneficial.
Oh, well, that's a very good point. I must admit, I've lent towards trying to talk those fellows out to this coming in every year for a PSA. I try and quickly turn the thing to what their weight is doing, and their weight. Being overweight carries as big a risk for cancers as being a cigarette smoker. And yes, in the scheme of things, their weight is actually a much bigger risk than their PSA. If their coming in for a PSA gives you an opportunity of talking about their weight or their other health and lifestyle things, well, then you might be able to justify it. But it's for a healthy fellow who doesn't have any symptoms, I don't know. I think it's not actually good medicine to keep doing a PSA on them every year. I'm going to stick my head out there. I don't know what others think about that. Let me see. We've got Subhashi. Well, I can see your picture there. You look glorious this morning. We have to go unmute you there, Subhashi.
Yeah, sorry about that. Yeah, I normally have a good conversation when they request a PSA, and I do talk. I do get a good history and ask about family history of prostate cancer, that type of thing. And if it's a first degree relative with prostate cancer, I might go for it. But I also explain to them that it's not a very definitive test. You can get even with low levels or normal levels, you still can have prostate cancer sometimes. Sometimes even with high levels, you may not have prostate cancer. So I do explain the benefits and risks of having the test done. And I don't do the test that often. People do understand when you try and explain to them exactly what the PSA test means. So yeah, I just take a approach case by case.
Yeah. Very good. Well, I'm feeling more comfortable. I was a bit nervous about doing this presentation because I thought, maybe I'm just a radical with extreme views. But I now realise I'm in amongst friends.
You know what, actually, okay, something else I was going to add to it as well too is that when someone actually comes in to see me for a PSA, I often actually use that as an opportunity to actually explore the IPSS score and see if there's any other symptoms that are suggestive of any lower urinary tract obstruction. And the actual big taboo topic, which no men talk about, is actually having any urinary incontinence, because I often do associate it more so with women, and therefore is another great opportunity to look at the overall holistic care of the men in the community that way.
Yeah, very good point. Okay, well, we've done prostate screening to death. I wanted to turn my attention. I could do you another drawing, but I've got you all. Okay. And that was osteoporosis. Now, that's my other pet hate at the moment. Of course, we're very open to overdiagnosis and overtreatment for the treatment of osteoporosis. Articles. I used to get the British Medical Journal. I don't anymore. We get in our surgery, we get the New England Journal of Medicine and the Lancet every week now. We're awash with magazines, but we do get all this wonderful information. But yes, some of the article I read suggested that osteopenia, this pre-osteoporosis condition, should be struck from the lexicon of language. It's a terrible expression and just produces anxiety. But if you look at the numbers needed to treat, was the article I read about who should receive treatment. Even in people with confirmed osteoporosis, the numbers needed to treat, well, it's once again very difficult to get consistent numbers. Every article tends to express it differently for different subgroups and things like that. But the article I read that you need to treat 160 people with Prolia before you spare one fracture. Now that's a lot of, that's 159 people receiving the treatments unnecessarily, you might say, or you don't know what the studies are no more than 5 years, so you don't know whether that's maintained over 5 years. Other studies suggest that if they have got osteoporosis, you can prevent a vertebral fracture by treating 40 people. But as far as hip fractures, which are the real killer, it's only it's about 150, 110, 150. Once again, it's pretty rubbery numbers you tend to come across. But I'd welcome your thoughts about whether treating 159 people to spare one person a fracture is a good return on our time, our efforts, the government's money. For the person who doesn't get the fracture, it's good value, but for the other 159, and in particular, when exercise improves your bone strength by 20 times, and that we should perhaps be exercising people rather than giving them lifelong Prolia. Now, I can see a few nods there, so I don't feel I'm sticking my head out too much, although I can see Chris Starling, he's on the computer, he's looking for the latest guidelines.
I'm trying to, yeah, I'm trying to find those figures.
Yes.
The 150, yeah, is that based on a certain T-score, or because I'm assuming that changes depending on your risk and T-score. And...
It does, and this is what makes it very difficult for you to come up with a counter argument, it to the patients. And the guidelines, it depends on whose guidelines you're looking at and all this sort of thing. Gordon, you're doing lots of nods, so I'll go to you first of all. What do you think on this topic?
Well, you know what, actually, I think one of the things I always think about is, do we always need to go to medications? And okay, is treatment itself a much broader term, whereas okay, your non-pharmacological treatment themselves are actually really important here as well. Before I was a doctor, I was actually a physio and working in the Jerry's units as well too at North Shore. Was one of my first placements I did as a physiotherapy student, and so therefore we were doing a lot of falls prevention classes, looking at people's strength and agility, being able to actually move around the community independently was what we're aiming for, and trying to optimize their actual overall function that way was actually found to be much more helpful in our scope of practice as a physio prior to actually then looking at medications there. So therefore, I actually beg the question, okay, do we actually always need to go straight to your actual your bone strengthening medications, like your Fosamaxes, your actual Prolias, etc.? Can we actually really push the lifestyle aspects more so than actually medications initially, and then try to actually see if it's not actually responding, then to actually take the extra step?
Excellent. I'll ask Oscar his opinion. And just before we go to Oscar, though, I'll give you a chance to think, Oscar. Yeah, I wrestle with this one every day. If I offer people options, lifestyle changes, exercising, things like that, weight loss, and if they don't participate, if they don't do their fair, is it fair for me to launch into medications and spend the government's money so they can just carry on the lifestyle they'd like to be? I feel a little bit of a responsibility that if you're not going to participate in the therapeutic relationship, I'm not going to participate. I'm working on you, but I'm not going to pay a shitload of government money so you can carry on doing what you like. I can see a lot
Ian,
of smiles.
You're sounding more and more like an orthopedic surgeon now. He would not operate unless a person stops smoking.
Yeah, I think I could have been an orthopedic surgeon in another. Oscar, what are your thoughts on those curly questions?
I think that's a really good thought, actually. The part that you said at the end, helping those who only want to help themselves kind of thing, is I think a very kind of important thing to consider in healthcare, especially in GP land. And yeah, with the numbers that you've kind of put out before, you know, lucky one person out of 160, but to spend, you know, all that PBS money on Prolias every 6 months for the 150 other people sounds like quite a waste, doesn't it? So, and I think Gordon essentially took the words out of my mouth in that, you know, there's, apart from medications, you know, doing resistance exercise and other exercise that essentially help with, you know, bone remodeling, or, you know, little like basketball and things like that, would probably be kind of more beneficial in more than one way, as opposed to bone health, you know, help with cardiovascular health as well. So I think, yeah, it's making me rethink how I'm going to tackle, you know, osteoporosis and T-scores and things like that when I start GP land in August. So yeah, food for thought.
Very good. A hand going up. Almut, come on in.
Has anyone else felt inadequate when the hospital started to write letters back for anyone who's had a fracture, especially postmenopausally, and they sent you the messages, can you please send through all your latest bone density scan? And I realized that I had a whole array of women who I hadn't done a bone density scan on for 3 or 4 years. And the majority of them, or 4 or 5 even, since that started, and the majority of them were really healthy and active people who, yes, I mean, by definition then, they had low impact fractures, but they are then put into this whole process of, you know, being investigated for, you know, osteoporosis and given the option in the hospital system. And now they're on the yearly checkups in the hospital, which on one hand is obviously good. But then I felt quite inadequate, thinking, oh my God, did I miss something? Should I have given them a bone density scan every 2 years? And then I realized that, you know, what we, quite likely you guys have been doing as well for the last at least 7-8 years of choosing Prolia as a first-line treatment, was also thrown all over the place and saying, oh no, that's actually not the first-line treatment for all those women who are still on the younger side of menopause and not the older side of menopause. Anyway, I have been talking to patients about that osteoporosis for me is the bane of my existence in general practice, to choose what to do with it, when to treat patients, and not just give advice, as Gordon, you said, you know, giving them advice on lifestyle factors and making sure they have enough vitamin D, calcium, and exercise in their diet and in their lifestyle. But feeling pressured now to avoid these fractures. And sometimes I really felt like, was that really a low impact, or was that really a significant impact fracture? Like, have you got the same? I don't know whether other people have felt the same thing, because by definition, I also had a fracture of my wrist, you know, typical Colles fracture, past menopause, and it was a massive impact. And I've, you know, I have decided not to treat myself because I really don't think I have osteoporosis. It was a massive impact. You know, that gray area in general practice has now come up repeatedly for me, because some of the patients who presented to hospital are now being managed in the osteoporosis refracture clinic. Does anyone else have the same issues?
Oh, exactly. I hear what you say, sister. Yeah.
Thank you.
Exactly right. So actually, we've got such an array of people there. There's a Renee Pop. I don't know your rest of your name, Renee, but if you're there, let's hear some of your thoughts as well. You might be wandering around your house in your pajamas with your earbuds in, so now you've got to rush to the computer. We'll accept that. Is Renee there?
Or she might be doing preschool drop-off, but I think
What about Kelly? We've got Kelly Unve. Kelly, is Kelly there? as well. Kelly, unverified. I have new microphone. Okay, fair enough, Kelly. We'll let you off. Christina, what about Christina? So I won't let anybody rest here. There we go. While Christina's coming online, just a comment there. So yes, this idea that everybody needs treatment for osteoporosis depending on your T-score and so forth, it makes me feel very uncomfortable. And yes, I find myself similarly wondering whether that's a high impact or a low impact fracture. It goes back to my whole ideas about prostate screening, but perhaps we should be waiting until we've got definite proof of a problem before looking for subclinical cases. So even with osteoporosis, waiting until somebody has had a significant fracture. I mean, it sounds at odds with what we'd like to do is pick up things early and give early treatment. But I must admit that that approach, has got lots of harms attached to it. And so waiting until the problem turns up may be actually more beneficial for a larger number of our patient population. Which then turns me to my next little topic of cholesterol therapy. Awesome. And maybe I could go to my whiteboard for this one as well. I'll try and, okay, screen broadcasting. Are you getting my whiteboard? It might have gone to sleep.
Oh, it's not there. You'll have to share it again, Ian.
Oh, thank you, Doug. There we go. I'll go back to my Teams. This might now go beyond me. I've now got the wrong screen coming up.
Looks like you're not logged in anymore on the iPad in the Teams meeting. It looks like you may have logged out of it because I can't see your other account on here.
I'd have to go log myself into the meeting. If you just bear with me, everybody, join now. Connecting. There we go. So now I can share my screen. There we go. Start broadcasting. The wonders of technology. Pen and paper works actually better. I thought about using iPads in the surgery, and then I could sort of, do fancy things like print it out. There we are. You're getting that screen now, and I'm going to try and rub that out. There we go. Rub that out. Oh, that's working. Okay. So yes, the little diagram, which is not dissimilar, that if we get 1,000 people who have a high cholesterol, and we do nothing for 5 years, then we expect about 175 of them to have some sort of cardiovascular event, a heart attack or a stroke or something of that nature. If we randomize them and people with high cholesterol as well, and we treat them with cholesterol-lowering drugs and things like that, we can expect at the end of 5 years to have 147 people have a cardiovascular event. And so, yes, we've made a difference to about 30 people out of 1,000, which is not, a great return from all those medications. And then against that, we have the side effects of cholesterol therapies, aches and pains, the expense of cholesterol therapies, and the going backwards and forwards to doctors to have your blood tested and get repeat prescriptions, going back every month to the pharmacist. That's a lot of traveling in cars. That's a lot of carbon that's been produced by all that activity where people could actually be lying on a beach instead. The equation changes if you take 1,000 people who have already had a cardiovascular event. If they've got cholesterol and you don't do anything for them, you can expect about 500 of them to have another cardiovascular event. if you treat these people, you can expect 250 to have a cardiovascular event, which means that you save about 250 people from having another cardiac event. Now that starts to become actually substantial numbers. But this is quite a difficult thing to explain to patients, that primary prevention, taking normal people with a high cholesterol, has little rewards and side effects, but secondary prevention, people who have already had a heart attack or stroke, does have actually quite good rewards. And patients immediately say to this, so you want to wait until I have a heart attack before you're going to treat me, doctor? And I say, well, yes, that's right. But as we heard earlier, the treatment doesn't have to be medications. And so if we could actually improve their lifestyle, help them lose weight, we could lower their cholesterol that way rather than having to use medications instead. Certainly once they've had a heart attack or stroke, they've declared themselves to be in a higher risk group. And yes, we can certainly justify, and I think the evidence is there that, well, triple therapy with aspirin and beta blockers and all those sort of things does keep these people going forever and ever. Amen, almost. So that little diagram I find helpful to explain to people about their cholesterol, because like their PSA, people get very worried about their cholesterol. They've heard from their friends and all this sort of thing. And this little table just helps explain that issue. I'll throw back to Dimity. Dimity, your thoughts on my drawings there? Just still on mute, Dimity.
I guess I've just been thinking about two issues. One is the dollar value of treatment. And when I think about my very older patients, and I'm getting more and more of those as I get older, you know, if they fracture a hip, for example, going back to the osteoporosis, 1 in 4 of them will die. I guess that's not expensive for the system, but it's not great for them. And 2 in 4 will remain bedbound thereafter over a certain age, and I haven't got the data on me. And that's what I was just Googling around for. And only 1 in 4 will be walking again. And so the bedbound people will require very expensive care. So then, as well as that being appalling for their quality of life. So I think we need to think about quality of life as well as cost. And I think we need to think about the effects at different ages. So someone who gets a fracture when they're 45, Collies or something, that's different from someone who has a hip fracture when they're 85, you know. And so there's one other thing I wanted to say, which is on a slightly different tack, which is because I think this is all a very complex problem. So the idea that we shouldn't spend money perhaps on people who don't help themselves, I think that's superficially attractive. But then I think about my patients with osteoporosis in their late 30s and early 40s who had eating disorders as adolescents. And I do not blame them for their eating disorder. I believe that's a mental health problem. And, you know, do we not screen because, you know, they didn't eat properly when they're adolescents, you know? And then I think about my patients with agoraphobia who don't exercise. And one who got very embarrassed because her cat used to come with her when she walked down the road, and she felt the psychiatrist had told her that she should at least walk around the block as to sort of as part of her therapy alone, but the cat came with her. Does that count? You know, I get so anxious, and the cat knows and comes with me. And so those sorts of mental health problems that stop people or doing what they ought to do, and often we, you know, it's hard to burrow into all of that. And I might sound like a bleeding heart, I know, but you know, the the longer you're in general practice, the more you uncover about people's awful, appalling, terrible, difficult lives that they've had and what they struggle with every day. And so I'm less and less inclined to be judgmental as I get older. Maybe that's because I'm looking at myself and thinking how far from perfect I am. I don't know. So I just wanted to throw those considerations into the mix. Quality of life, the fact that people aren't always as free to do what they ought to do as they should be, and that might not be their fault, and also that that the cost at different ages of not identifying and treating something needs to be taken into account as well. Yay. Thanks for giving me that opportunity to get all that off my chest, Ian.
Oh, this is a therapeutic session. There we go.
Thank you.
What about Chris? Chris has got his hand up there. Off you go, Chris.
Yeah, I'm not as insightful, but my question is very simple. It's just coming back to the initial drawing you did in, and I might have missed this, just when you're talking about primary prevention, does that those figures take into account whether the patient's low risk, intermediate, or high risk in terms of their cardiovascular risk? Because that's how, because that obviously changes it for me.
No, it doesn't. No, it was just a collation of stuff I suppose I've read over the years, and I think the original study that had me thinking was just the general population, 1,000 people in the general population, but with a cholesterol above the normal range. But yes, so that's where we try and manipulate these algorithms ourselves by trying to find out the high risk people. And now we had a talk the other day about the low density lipoprotein C that we should all now be looking at and treating that one as well. There we go. Well, I've got this great big list here. This is very exciting. Melissa, is Melissa there? Does Melissa want to add a comment to the morning's proceedings or flag something, Melissa?
Oh, yeah.
Yeah. Well, yes. Off you go, Ruben. Yes, I can see you, and you off you go. Yes.
Sorry, I just wanted to say that some of the things that Dimitri said. Gone are the days in the 70s and 80s when governments recognized seeing all these fractures of neck or femur and spending a lot of money on orthopedics. And so I think I haven't seen any studies to see whether we have reduced the number of internal fixations of fractured necks of femur for osteoporosis. So I think certainly we need to, as GPs, we need to actively monitor bone density and do the best with the treatments. In addition to the lifestyle measures, because we are going to save a lot of money on public health on the expenditure side with trying to do surgeries for fractured neck of femur. So, and as people live towards 90s and 100s, I think we will save a lot of money. I don't think the cost on the anti-resorptive medications will matter much as opposed to the amount of money you save on each person's surgery, because as you know, if a person has fractured neck of femur and they have internal fixation, they're going to spend 5 to 7 days in the hospital. All that cost put together, the anti-resorptive medication probably won't be as bad in terms of cost. And also I wanted to say I've stayed away from Prolia over the last 1 year. Most endocrinologists don't recommend Prolia anymore. They recommend more Actonel or the IV zoledonic acid infusion, because Prolia, if the patient accidentally stops and we don't recall them at 6-month levels, then the reduction in bone density is far steeper than if they were on Actonel. So I've stayed away from, most endocrinologists are not supporting initiation of Prolia, so I've stayed away from Prolia over 1 year, mostly using Actonel biphosphonates or sending them to the hospital for the once a year IV zoledonic acid infusion.
It does make you very circumspect, doesn't it? Because the same endocrinologists 3 years ago were telling us just how wonderful these new treatments were. So yeah, there we go. I think our time has come. We better wrap up there. I'll throw to Georgie or Sydney. Who should take the floor?
I'll just quickly pause the recording here and say thank you, Dr. Charlton, for that. That was brilliant. Let me hit stop. There we go.